Thanks, Neil. This talk is on a little bit more detail on pelvic floor rehabilitation. We sort of call it pelvic floor physiotherapy in Australia, alternative altogether with surgery. And this all started when Gabrielle came to Brisbane a couple of months ago. We had a conference on colorectal pelvic floor disorders. And pelvic floor physiotherapy is very much accepted in Australia as initial therapy for pretty much any patient. And the vast majority of surgeons understand that and will refer to pelvic floor physiotherapists. There is a big difference between a physiotherapist and a pelvic floor physiotherapist, a huge difference, chalk and cheese. And there is also a difference between a pelvic floor physiotherapist and a pelvic floor physiotherapist who has done specific training in anorectal dysfunction. So I'm not talking about physiotherapists who tell women to squeeze their pelvic floor muscle after they've had a baby. There's many pelvic floor physiotherapists who do this. I'm talking about highly trained physiotherapists who have undergone further training in anorectal dysfunction. Anorectal dysfunction is fascinating. And physiotherapists, once the light bulb goes off and they realize how interesting pelvic floor dysfunction is, anorectal dysfunction in particular, and what a difference they can make, they all actually get very excited and want to become part of it. But at this conference we had many speakers, many surgeons, many gynecologists, but we also had many physiotherapists talking at this conference, and the physiotherapist talks were some of the best talks and the most well-researched talks with the highest levels of evidence of the entire conference. So, hence that's where this is coming from. So, key principles. So, whenever we treat anyone, we always have to look first of all is what is the problem that we're treating, and what are the options for treatment. So this is the same with anything. But importantly, when we look at the options for treatment, they come with risks. So what is the chance that I make my patient worse with this therapy? What is the chance that something goes wrong? What is the chance that the patient leaves worse off than when they came to me? That would be terrible. In particular, terrible for a benign disorder. If someone comes to you with cancer, it's a bit different than if someone comes to you and they can't poo properly. If they come to you and they can't poo properly and they leave much worse off, they're going to be pretty unhappy. And then what is the chance that my therapy is going to work? And as we know, whenever we're treating anything, it's a balance, isn't it, between what's the chance this treatment is not going to work or is going to make my patient worse versus what's the chance it's going to work. And I would argue that with pelvic floor physiotherapy, it's very unlikely you're going to be worse. It's very unlikely a pelvic floor physiotherapist is going to harm you, induce morbidity, kill you, anything like that. There's a chance the physiotherapist will make you better. I can't tell you how high that chance is, it depends what they're treating, but the risk of having physiotherapy is very low, and so it's certainly something that we should think about. So my answer to your question, Gabrielle, is it's an alternative. Of course it's an alternative. As I've shown in my presentation, it's an alternative. Many patients have avoided surgery or perhaps delayed surgery, but it's also potentially something you can do with surgery, and so it may be something that you can do before surgery or after surgery. It's important if you've done something to try to improve the anatomical derangement, it's very important that you improve the physiological derangement, which may be the reason that the anatomical derangement happened in the first place. And if you don't do that, you're going to get recurrence. And what we do at all these congresses is we talk about recurrence as if it's the operation's fault. It may not be anything to do with the operation. It may be that the operation was done well, but the underlying functional problem was not addressed after the surgery or before the surgery or both. And if we address the underlying functional problem, then perhaps our recurrence rates will be lower. So again, it comes down to functional disorders, structural disorders. We need to expand our thinking and not think of pelvic floor dysfunction as purely a surgical problem. We've got high pressure and straining is the enemy and is often the cause of worsening prolapse, stretching out of important connective tissue. And if we can improve this, we might be able to get the patient out of that vicious cycle that they were in. This paper I found very interesting. It came from, I think it was Holland, someone doing their PhD at, where's Groningen? somewhere in Holland maybe.
It's the most northern city.
Oh, there you go.
Small country.
There you go. So Dutch PhD, and he looked at patients with symptomatic hemorrhoids, and he found that more than half of them had dyssynergic defecation as well. And in my experience of treating hemorrhoids as well, if you operate on those patients with dyssynergic defecation, they'll be the people that have a lot more pain after their surgery. And it's very important to try to address that, ideally preoperatively if you can. And I wonder if this is a risk factor for recurrence after surgery for hemorrhoids. So we have all these sessions on hemorrhoids. We all talk about recurrence as if it's the fault of the operation. Perhaps if we just address the underlying cause of high pressure, then recurrence rates will drop. So pelvic floor rehabilitation aims to reduce pressure, and it aims to restore a normal defecatory technique. And so what I'll often do is I'll try to examine my patient ideally on the commode. Occasionally I'll examine them in the left lateral position if that's not possible, and try to get them to simulate what they do when they go to the toilet. And I comment on a poor defecatory technique. And so the classic will be someone who goes red in the face, puts a huge amount of abdominal effort in their abdominal muscles, and then you can actually see their buttocks contracting and their sphincter contracting and their perineum going up. So that would be classic type 1 dyssynergia. So all they're doing is generating a huge amount of pressure and causing hemorrhoids and causing prolapse and causing all kinds of fissures and all kinds of other problems, and it's very important to address that. So a normal defecation, what's normal? There should be an urge you need to have an urge to go to the toilet, but without having to rush. We should be able to hold on. It should take only a few minutes. There should be minimal effort. Ideally the stool should be formed but soft. So Bristol type 3 to 5. So obviously if you've got someone who's got type 1 stool, well, that's where you've got to start. You've got to get that stool that's being delivered to the rectum to be a better consistency. It should be painless. We should be able to empty completely, and the frequency should be about 3 times a day to 3 times a week. So functional constipation, the symptoms that we often ask about in obstructed defecation, do you strain? Do you have hard stool? Do you have a feeling that you don't fully empty? Do you feel like you're blocked? Do you have to use the finger or the hand somewhere on some part of your body to assist with defecation? And if they do that more than 25% of the time, then they satisfy criteria for functional constipation. And functional constipation, together with IBS-C, if these patients have 2 of the 3 of abnormal balloon expulsion, an imaging study showing inadequate evacuation, or abnormal evacuation on manometry or EMG, then they have a functional defecation disorder, and that may be dyssynergic defecation, or it may just be inadequate propulsion or poor technique. But a physiotherapist isn't the only member of the pelvic floor team. As we know, there's the surgeons, the nurse specialists are very important, the dietitians are important. There's also psychologists, gastroenterologists, so they are part of a much bigger team, but I would say they're probably the central part of a pelvic floor service. So conservative therapy is so much more than just going to the toilet properly or sitting in a normal position. We know that for obese patients there is now evidence that if they lose weight, then pelvic floor symptoms improve. And often with obese patients, we'll often spend time working on that and talking to them about that. Smoking can contribute, dietary factors, as you know, and toileting habits. This is something called a squatty potty. I don't know if you have it here, but a more physiological way. So there's been studies out of Japan that have shown that evacuation is improved if your feet are elevated. So you can either pay €50 and buy this, or you could just get a block of wood and use that instead. It's a little bit cheaper, but it has been demonstrated that defecation is improved in that more physiological position. It's important that patients understand triggers. They understand that going for a walk, for example, an elderly patient, if they go for a walk, that'll often follow with an urge to go to the toilet, and the use of the gastrocolic reflex. So after eating, that's often when we'll get an urge to go to the toilet. And I think that's one of the problems with our Western world is we wake up in the morning and then we have this huge breakfast, and then we jump in the car, and when we get our gastrocolic reflex, we're stuck in a traffic jam somewhere, and then we hold on, and generates all kinds of problems. There's medication, and these are usually used for patients with diarrhea or loose stool. So what does a pelvic floor physiotherapist do? So they're really a holistic approach to optimizing the way you go to the toilet. They'll talk about timing. These people are really experts in optimizing your entire lifestyle and giving you ways and helping you with coming up with ways to improve the way you go to the toilet. They'll give you dietary advice. They'll tell you what laxatives to take. They'll give you advice on fiber supplements, when to take them, how to take them, what particular fiber supplement to take, and what position you should use when you go to the toilet. And then there's biofeedback therapy. Biofeedback therapy aims to actually reinstitute a normal technique. I was telling you about our young man before who was probably a bit too difficult to treat, but people who get out of kilter and they find that their muscles are not coordinating properly when they go to the toilet. Biofeedback therapy aims to improve that. They can even do what we call volumetric rehabilitation, so patients who have hypersensitivity or hyposensitivity, the physiotherapist will put a balloon in their rectum and blow it up and try to slowly over time alter that. For patients with pelvic floor pain, chronic pain, hypertonia, they may be able to do fascial release, find an area that's tender and gradually massage it, and those patients can also have an improvement in their pain. So they're really, really experts. What do? They'll examine the patient, look for a contraction of the sphincter, watch what you do when you're pushing to go to the toilet. Strain means pushing to what you do when you're on the toilet. They want to see your perineum descend a little bit, and they want to see your anus actively open. And if they don't see that, then they'll work on ways to try to re-educate those finely tuned reflexes to occur again. They'll do a digital rectal exam, feel for muscle tone, feel for a coordinated movement. We ideally need to bulge our abdomen out when we go to the toilet, and they'll work on that. They talk about the abdominal bulge, and they use all this in a physiological position, so that in a sitting position for going to the toilet. So they've got an educated finger too. So what's biofeedback therapy exactly? So it just means that you're getting some visual feedback or some form of feedback on what your body's doing. Because when we go to the toilet, we don't really know what we're actually doing. We don't think, oh, I've got to relax that muscle and I've got to pull that muscle. We just go to the toilet. It's a reflex. And sometimes we can get out of kilter. So for example, you could even use a mirror or an ultrasound or even feel your perineum when you're pushing to go to the toilet. And then you can work out, oh, hang on, no, that's not right. I'm not doing the right thing there. Now I'm doing the right thing. We often use a lot of EMG, surface EMG, so we'll put a sticker on the perineum or just next to the anus and ask the patient to push as if they're going to the toilet. And the EMG will show if they're contracting or if they're relaxing. And so that can also be useful. Sometimes we put a balloon in the rectum to simulate a more normal defecation. So what's the evidence? Biofeedback therapy is most effective by a mile in dyssynergia. So if you see someone comes along to you, they've got obstructed defecation, and this history suggestive perhaps of dyssynergia, usually you've got a feel about it from the history. You examine them and you say, I want you to push as if you're going to the toilet, and they clamp down their anus and clamp their buttocks down, and you put your finger inside their rectum and their pubirectalis muscle contracts and closes off the anus, and they've got dyssynergia. They're probably going to get better with biofeedback therapy, and don't operate on them. And so there's 3 randomized controlled trials which have shown that biofeedback therapy is better than basic standard care and laxatives for these patients, and that's in all kinds of different forms of biofeedback therapy. What about fecal incontinence? There were earlier RCTs that showed good results, but 2 recent, well, when I say recent, a little while ago now, randomized controlled studies have shown that if you have biofeedback or exercises or standard care, you get better no matter what you get in patients with just fecal incontinence. What about prolapse? A study that looked at patients with internal rectal prolapse who had biofeedback therapy. About a third of them had resolution of their constipation with physiotherapy, partial improvement in another almost 20%. The famous POPPY trial, which was a very well constructed major multi-center randomized study from 2014, looked at almost 450 patients with vaginal prolapse, so their problem was vaginal prolapse, and they randomized them to get nothing or pelvic floor muscle exercises, and there was a statistically significant improvement in prolapse symptoms at 12 months. Surprising how physiotherapy can make prolapse better, but certainly the symptoms seem to get better, probably just with optimization of technique. They've still probably got the prolapse, but their symptoms are better because we've optimized all those optimizable factors. So as I showed before, Results from physiotherapy for us, high patient satisfaction. Many patients are happy to continue as they are. That's at my table from my last presentation showing our overall results. But I also want to talk about the dietitian, as I mentioned before. What about the dietitian? So we published last year that dietitian-led service that I told you about earlier. There were 126 patients who were treated in this dedicated dietetic health clinic, so they were taken off our waiting list before we'd seen them, seen by the dietitian. 44% of them had defecatory dysfunction, 26% fecal incontinence, and then you can see the others. And so what we did was a diet quality tool questionnaire, and we found basically that in the vast majority of patients there was a very, very poor fibre intake, and I think you could probably generalise that to most of Australia. And our intervention was an individualised healthy eating program, a focus on fibre and fluid, and fibre supplements. And the fibre supplement that we used across the board was Metamucil in this one. Second line therapy included a low FODMAP diet, an elimination diet, or probiotics. So these patients were just seen by a dietitian, and a quarter of them were completely fixed. Quite incredible, and if you think about it, much cheaper than an operation. So a quarter of these patients had complete resolution of their symptoms, 17% were lost to follow-up, and 58% continued to go on to see us, and they were very happy with the service as well. So even a dietitian, not just a physiotherapist, has a key role in the management of pelvic floor patients. So pelvic floor physiotherapists are experienced clinicians. They've got an ability to assess patients in the context of their symptoms and provide a very holistic service. They'll look at behaviour, toileting habits, laxatives, supplemental therapy, and they'll optimise the way they go to the toilet. And these measures may address the underlying cause of what's actually caused the problem in the first place. They may mean surgery is not necessary, or they may even just delay surgery. And they're certainly also a useful adjunct to surgery. So I think it's a crucial part of any pelvic floor service, and every pelvic floor patient should have access to it as part of their holistic care. Thank you.